We're going to bring on our next panel or presentation, and this is heavily cool. I got a chance to meet Jacob, one of the people in doing this, and we were hanging out last night. And it's called How Analytics Can Impact Change from Poverty to Culture, Social and Economic Prosperity. So there's Maria Savidov, is a business analyst for Bissell. Jakob Koziel, is it Koziel? We were just first name basis right away. So it's Jacob Koziel.
Yeah, got it.
And Greg Horne, the Global Principal for Healthcare for SAS, another great company in there that does a lot in the analytics world. I'm going to turn it over to you guys. I'm just here to watch, so take it away.
Awesome, thank you. Hello, everyone. It's a pleasure to be speaking to everyone here today about the work that Bissell Centre has been doing with data. Bissell Centre respectfully acknowledges that we are situated on Treaty 6 land, the homelands and gathering places of the Blackfoot, Cree, Plains Cree, Saulteaux, Dene, and Métis peoples. Their history, traditions, and perspectives are so valuable to the community that I'm grateful to be a part of. For those of you who might not know, Bissell Centre is a community agency in Edmonton, Alberta, Canada, that seeks to empower people to move from poverty to prosperity. We have a variety of programs from housing and eviction prevention to employment, childcare, mental health, etc. And we, of course, collect data on all of these. So just to introduce ourselves a little bit, I'm Maria Savidov. I'm the business analyst. As Jim said, I design operational data systems to fit our context and data needs and ensure we have the right tools being implemented correctly. And I really loved the data governance sessions today, and I learned a lot. Having said that, I don't have any background with SAS, but I collaborate closely on evaluation and data project with our research analyst, Jacob, who does.
Hi, good morning, everybody. As Maria was mentioning, I'm the research analyst at Bissell Centre, and I analyze the data that we both collect using quant and qualitative methods as conduct claims and create data visualization products such as dashboards, infographics, and other products to visualize and present our data.
So the goal for this presentation will be to provide a brief overview of the data we have and to also provide some examples of the types of analyses that we've been able to do. I'll start with an overview of the types of data we collect, then I'll speak a little bit about our self-sufficiency matrix, which is the central tool we use to measure participant outcomes, and then I'll hand it over to Jacob to talk about the types of analyses he's been able to do with SAS. So, to provide you with some context, here is a highly simplified workflow for participants through our services and examples of data that is collected at each stage. As an aside, we also have a passion for data usage and stewardship, and I got some really great ideas today as well. And in terms of privacy, we have our data use and storage tenet, or DUST for short, where we let our participants know in plain language about the data that we collect and how we use it. So just to walk you through a little bit, starting point is our intake process, and we collect some demographics information about their life situation using the self-sufficiency matrix, which I'll talk about in a little bit, as well as their needs and goals. Then we have the referral stage where they're referred to services that they need, and we collect information like where they were referred, the wait time, the referral success, etc. The biggest chunk of the journey is case management, and we collect case notes, referrals as needed, and program-specific data. And then we have outcomes, which is the other bookend to starting point, where we reassess their life situation at 3, 6, 9, 12 months and exit. So to talk a little bit more about our starting point, as I mentioned earlier, we have a lot of different types of services and programs with a variety of funders and reporting requirements, which, as you can imagine, can get very disjointed and siloed if left unchecked. So to answer the question, are we moving the needle on poverty? We have created the starting point process, as I mentioned, as a way of weaving a common thread through participant outcomes within the organization. And we selected the self-sufficiency matrix, which has been used in various social work and academic settings as our primary measurement tool. So currently for us, it measures participant self-sufficiency in 6 different domains: housing, employment, financial well-being, support network, mental health, and physical health. The steps are: 1, in crisis, 2 vulnerable, 3 stable, 4 safe, and 5 thriving. Bissell's self-sufficiency matrix has actually undergone a revamp since we first started using it, which improved inter-rater reliability from 30 to 80%. And most notably, we replaced a subjective Likert scale format for the domains with a more objective decision tree format, where the score is calculated through a series of conditional yes-no questions. This format was developed by LifeWorks in Austin, and we adapted it to Edmonton's context. And to talk about some of the significant questions we can answer with this and SAS, here's Jake.
Thank you so much, Maria. So for this portion of the presentation, I'll just talk a little bit about how our department has implemented SAS in our everyday operations. I've used SAS in the past in my previous roles, and I find that it's a great tool to use for the work that we do, and also the fact that there's such a massive amount of resources available through ebooks, forums, videos, and etc. that one can tap into if anyone has any questions. Since our department has connected with the amazing SAS team, we've been able to use SAS to analyze our data in a number of ways, from quantifying how Bissell programming impacts Edmontonians experiencing poverty, to giving us an idea of where we may need to pivot our programming to better meet the needs of our community members. The use of SAS has also been instrumental for us in answering our first sets of questions, and that is, who are our community members that we serve? So in other words, trying to get a better picture or profile of who is accessing Bissell Centre programming. So for this portion, I'll just be providing some quick examples from some of the previous projects that we have worked on at Bissell Centre, utilizing the ETO data that Maria just presented. So at the simplest and very basic level, SAS does a great job in giving us the ability to produce simple frequency and percentage counts at a very quick turnaround for whatever data needs we need to present internally or externally. As a side note, I really actually like the proc univariate command from SAS, as it allows us to look at the skewness and kurtosis of our data and our distributions. And it also gives us the ability to take a first look, a very general look at whether our data is normally distributed or not. And even though that's very simple to do in SAS, it's actually very important in our initial data explorations, as it allows us to determine whether we should proceed using parametric or non-parametric methods to analyze their data. So we're not misinterpreting anything or misanalyzing anything as well. Now, with these simple commands, we can report back to our managers and directors and other stakeholders to answer some questions, such as on this slide, how many starting points were completed at Bissell in 2020, and who's been accessing our programs, broken down by age groups, ethnicity, gender, citizenship, and household groups as well. But for those of you here who do use SAS, you all know that it has thousands of other more advanced techniques at its disposal to analyze data. Now, for us, we've been able to leverage some of these techniques to measure if there are any groups that are more susceptible of having worse starting point scores than others, and where we may need to pivot our programming in light of this information. One example comes from an evaluation that Maria and I did last year for one of our programs, which is focused on providing financial empowerment and coaching to Edmontonians experiencing poverty. Now, in that evaluation, we were interested in understanding the number of financial coaching sessions that have been conducted and the potential reach of financial coaching at Bissell Centre. We were also interested in looking at the association between someone's financial well-being scores when they first walked into Bissell Centre and the different demographic groups that you see in this table. This table summarizes information from a multivariate ordinal regression model, and we found that those identifying as Indigenous were associated with lower odds of reporting positive financial well-being when first coming to Bissell Centre, compared to those who did not identify as Indigenous. And we also found that individuals younger than 45 had worse financial well-being scores when arriving at Bissell Centre compared to those who were older than 45 as well. Now, at the time, this information was used to report back to the funders of this program, but was also used by the managers to better understand their program and potentially use the information to tailor their program around these more at-risk groups. More recently, we've also been able to utilize other techniques, such as latent class analysis, to see if we could better group the community members that we serve. Now, in order to serve our community members well, it's important that we first see, are there any unique subgroups that exist and what their needs are, so that it would better enable us to develop tailored interventions that adequately meet the needs of each unique subgroup. Now, for those of you here who haven't heard of latent class analysis, LCA is a technique that identifies hidden subgroups of individuals among one or more populations, and it slots individuals into these different groups or classes based on how each individual responded to a set of binary questions. Luckily, SAS has a really great tool that was developed by Penn State University, which allows SAS users to conduct this kind of analysis amongst others as well. For us, we wanted to categorize people based on whether they were in crisis or not in each of the 6 BSSM scores when they first came to Bissell Centre into different latent classes. We have also used latent profile analysis as well and kept the scores as Likert scales. Now, I won't get into the nitty-gritty stats of LCA, but one of the strengths of LCA is that it produces a series of statistical model fit indices, which helps the analyst determine the optimal number of groups. For more complex data sets, it also allows one to adequately summarize and distill thousands of groups into smaller, more manageable, unobservable latent groups as well. Now, for this analysis, based on routinely indices that's labeled on the slide here, we found that a 3-class model was ideal. And so, in other words, individuals were categorized into one of 3 groups. Approximately 22% of individuals belong to the first group, 21% in the second, and 57% in the third. For the second group, everyone was in crisis or vulnerable regarding their physical or mental health, and everyone in the third group was in crisis regarding one or more domains revolving around their financial situation. Now, it makes sense that more than half of individuals would belong in the third group, seeing as how the majority of those who require our supports and services, it's really focused around addressing their economic situations. But the one thing that's really apparent from this analysis, and pretty much every research on individuals experiencing homelessness, is that they're composed of largely heterogeneous groups with different challenges and requiring different approaches. So for those accessing our services and supports, we confirmed that there were in fact 3 unique subgroups of individuals, and moving forward, we're hoping to eventually use latent class regression models, which you could do actually with PROC-LCA, to model the BSSM outcomes of these 3 groups who have participated in the program, while of course controlling for various covariates, and see if one group outperforms, for lack of a better way of saying it, another group. So if class 3 individuals have better outcomes than, let's say, individuals in class 2 as well, and also allowing us to answer why that might be the case. Now, speaking of outcomes, and speaking of seeing the impacts of our programs on our community members, and to use analyze the data that we routinely collect using our ETO database system, we also conduct more in-depth evaluations of our many diverse programs as well. And oftentimes, we will collect data through the use of surveys, collected at retrospectively or at pre-post time points, to answer, is this Bissell Centre program or programs positively impacting people's lives? Now, one of the evaluations where we wanted to answer this question was focused on our childcare program, specifically our Respite childcare program. Our childcare program is especially important for families and their children in the Edmonton area, especially during this pandemic era, as unfortunately there are a number of sector gaps that currently exist for parents accessing childcare services, including high costs, wait lists, and additional fees for being placed on wait lists. In fact, in Edmonton and Calgary, close to 40% of childcare centers in 2018 charged caregivers fees to put their children on wait lists, with wait list fees being as high as $200 per child. Now, oh, I'm just seeing that my internet is flaky. My apologies for that. One unique program that actually has been instrumental in addressing these sector gaps and the etiology of family poverty has been the Bissell Centre's childcare program. Now, this program provides full-time and part-time or respite childcare for families in need and employs an early childhood development resource worker, and it does not impose any wait times or wait time fees for families as well. And the worker also helps to address the root causes of poverty by supporting caregivers where they need the most support, including but not limited to providing essential supplies like diapers and formulas, as well as referrals to other available supports that the caregiver needs. Now, back in the spring and summer of 2020, our department was asked to conduct an evaluation and measure how much of an impact our Respite childcare has had on parents in these outcomes that you see listed here, from their ability to pursue educational opportunities to their relationships and support networks. So we implemented a retrospective pre-post survey to 55 families who access our Respite program, and we asked them how much their childcare duties prevented them from engaging in outcomes related to moving out of poverty before accessing the childcare program and after, so that we could determine whether the program actually actually made a difference in reducing the burden of some of these childcare duties. Now, the questions were scaled from 1 to 10, with 1 being that childcare duties had no impact on their ability to pursue educational opportunities, employment, etc., while 10 represented that there was a lot or significant challenges that effectively prevented them from almost completely, if not completely, pursuing these different opportunities as well, or impacting these different outcomes. Now, for this analysis, we ended up using Wilcoxian signed rank tests because we found that the data was, not surprisingly, highly skewed with significant outliers present as well. The red dots that you see on the slide here represent the parent median scores before bringing their children to our Respite program, while the blue dots represent the challenges or the median scores of pursuing these outcomes after bringing their children to the program. Now, not only, as we can see from this slide, were all outcomes significant, but we can also see that the effect of the Bissell Respite childcare program had an enormous impact on reducing challenges for each of these outcomes. In fact, the changes were quite extreme, actually. When we take a look at employment, parents literally went from one extreme before bringing their children to respite care, being that childcare duties posed enormous challenges in pursuing employment opportunities, to then childcare duties posing no challenges for parents pursuing employment activities after bringing their children to childcare. So the quant data told us one story of our program, but we all or the human data story had to tell us as well. So in our survey, we also asked parents open-ended questions, and we found that the responses actually supported some of these extreme changes that you see here on this dumbbell chart. According to one parent, if the program were to end, my business would fail and I wouldn't be able to have time to access therapy. The closure would impact my life a lot. Another parent said, it's really helpful as I can schedule interviews, appointments, and do part-time work. It's perfect. It would even be better for me if I could drop them off more than twice a week. So to recap, these analyses that we've been able to do with SAS gives us the opportunity to present our successes and the impacts of our programs, such as our Respite childcare program, to funders, the public, and to other stakeholders. But it also gives us the opportunity to ask, what can we do better to serve our community members? Because we can always do more and improve when it comes to eliminating poverty in our communities. So to summarize what we just talked about, all the work that we do in our department revolves around supporting our programs in their efforts to eliminate poverty in our communities. The EDO database system and our self-sufficiency matrix process that Maria created and built and presented today allows us the ability to store and retrieve our data, measure where people are at in life, and give us the flexibility in being able to customize our reporting based on the needs of managers and directors. To give meaning to the data and to improve our understanding of who's coming to Bissell Centre and adjust our programming where needed, as well as the ability to evaluate whether our programs are actually moving the needle on poverty, SAS has been instrumental in answering these and many other questions and leading us more towards further eliminating poverty in our communities. Now, when it comes to our future, we're currently now in the process of cleaning 2.5 years worth of starting point and outcomes assessment data to measure whether or not our programs led to improved or worse BSSM domain scores. And since we have a mountain of case notes, we're hoping to use SAS's text mining software to try and make sense of those case notes. Also, with a greater sample size, after many years of data collection, we can now go into and start to utilize techniques like regression trees, structural equation modeling, among many others, and start answering other data-related questions that we're interested in answering. And lastly, we're also very much open to partnering and working with universities and other organizations as well on projects that are focused on helping to eliminate poverty in our communities and assist our organizations as well as the ability to potentially and ethically, and I'm thinking about the presentation yesterday and wanting to overemphasize the term ethically, share and link our data sets with other healthcare data sets. So that's it for us. Thank you so much. It was truly an honor and a privilege to present here today. Thank you so much to the organizers of the Big Data and Analytics West Conference, and a big shout out to the SAS team, Nina Haas and Nick Sandy, among many others as well. So thank you all so much.
Brilliant. Thank you, Jacob and Maria. That was a great presentation. And so I'm Greg, I'm with SAS, and I've just got a few minutes here now to talk a little bit about how we see the trends that they just described in that presentation from Bissell in the rest of the world and what we're doing today. And one of the things that's really important for me is to understand how people are progressing on an analytical journey. And to that end, what we've been doing in this space is really helping folks to understand where on the kind of progression scale the work that they're doing is. And for some reason, I cannot advance. Okay, here we go. So what we do here is when we go and speak to people who are looking at doing more with healthcare analytics, we want to help them understand the kinds of questions they're trying to answer. And that's really important because if you can start to think about the outcome you're trying to get to, if you can think about the thing you're trying to improve, and in the case of Bissell Centre, you can see they had a number of very specific and strategic areas they're looking to improve. You can start to understand what kind of analytical processes you need to do. And so often when I sit down with people, when we start a conversation in this space, we think about these questions. What are the questions you're trying to answer right now? But more importantly, as we move forward in that, we're starting to see now this real change in the way that people are coming to the analytic question. And you saw that in the last presentation there from Bissell, in that they're not just using healthcare data to understand healthcare problems. And this is a thing that we're starting to see as very much a trend, this idea of social determinants really driving the changes in healthcare. But also we're seeing that the people who want to engage in analytics are no longer just the data scientist or the analytical departments within hospitals and in other health settings. We're seeing that the clinical users, the business lead, and now even more the patient is becoming much more involved in that decision. And when we see that, we also see that their locations are changing and healthcare is now being delivered in many more different places. And we have people like Bissell Centre, but we have other community-based healthcare environments that are springing up that need both access to data and a way of using the results of their analytics. So in the middle of this, we talk about the cloud, and we see most of what we're doing today is moving up to the cloud. But when we think about our data sets that we're seeing be brought into play, the key ones for me right now are social determinant data and device data. So we're getting a lot of requests now to understand how to implement data solutions using those social determinants, and we'll cover some of those in just a minute. But the device data is becoming so much more important as well. And by devices, we're thinking about care in the home, care in the community. It's not just things like Apple Watches and the like, it's home-based blood pressure monitoring, home-based diabetes monitoring and the like. And all this data is coming together to really help us understand how to keep patients out of hospital, in their own homes, but in the best state of physical well-being that we can achieve. And at the end of this, we think about our outcomes. And there are a number of places where analytics is really driving outcomes. But the one I always want to pick up on is this idea of value-based care. Paying for those care episodes that actually change the journey for the patient, and changing the patient's outcomes by making sure that people with multiple chronic conditions and the like have a very connected healthcare experience. And we really want that to become very patient-centered. And if we can achieve that, then we can start to see some real improvements in patient care. Now, what's become important here, and I already mentioned this idea of social determinants. So this piece of work has been used and kind of reproduced around the world. This particular example is comes from the US, but it's just because it's a very nice diagram that shows it. But what we're seeing now is factors of social determinant are playing a much bigger role in health outcomes than healthcare itself is. And when we think about an analytical approach to this, we must bear this in mind, particularly if we want to produce ethical algorithms, we want to be free of bias, and we want to apply our healthcare across our entire population. So, you know, in that last presentation, we saw that financial issues play a big role in the work that Bissell was doing, and we see that in healthcare in general around the world. But it's not just those kind of financial things. It is our health behaviors. It's, you know, do we have access to exercise and clean water and fresh air and good food and access to the internet and knowledge and good quality water? Do we have good sanitation? It's all of these things coming together that make a real difference. And when we see in a healthcare system like we have here in Canada, this idea that everybody should have equal access to a publicly funded and publicly available healthcare system, we see in the real world that doesn't play out in that way. And these social determinants act often as barriers to access to care and barriers to the ability to see care through, particularly when some things are not always covered by provincial schemes. And so being aware of how these social determinants play out for patients becomes even more important. So we have a case study here from CAMH, the Centre for Addiction and Mental Health, which is near me. I'm in Toronto. And it's a really nice example of how social determinant data coupled with clinical data has been used to understand how beds are being utilised within the hospital and help patients get into more appropriate care. And in this particular programme, patients are now they're assessed at admission. They're giving a score based on that admission criteria as to their likelihood to use a bed for an extended period of time. And that score is used to flag those patients to be pushed to more appropriate care right from the point of admission. And what was recognised at the hospital was that there was many people in beds, bed utilisation by patients who didn't necessarily need hospital care, but there was another factor that was preventing them from being discharged. Now, using analytics from healthcare data and social determinant data has enabled the hospital to free up that bed capacity and put people into that more appropriate care where they can have better outcomes. And better outcomes, of course, is better for everybody, not just for the patient, but also for the clinical staff who are trying to work with and help patients onto a speedier recovery. And this particular example has been rolled out in CAMH, which is a mental health hospital, very similar to the work that Jakob and Maria just described. But we are actually now just about to do almost exactly the same use case for the entire United Arab Emirates, who are looking as well at how they can speed patients through their system and provide more appropriate care. So we can see that's two examples globally where this exact piece of work has been very relevant. The last thing I want to leave you with is this year we've been making a podcast here at SAS. It's called The Health Pulse, and I present it, and we have 14 episodes available on your podcast distributor of choice, be that Spotify, Apple, etc. But we just started releasing episodes through our YouTube channel as well. And we have a couple of episodes that we've just released that are very relevant to this topic. Just a couple of weeks ago, we had Dr. Robert Wynn, who runs the VA Cancer Centre, Massey Cancer Centre, and he's talking about this idea of the space that you live in and how social determinants really change health outcomes. So I would really recommend, if you have some time, if you go to the SAS YouTube channel, you can find those episodes, and that episode in particular, where we talk about how social determinants play out in cancer care and cancer treatment. So I'm going to wrap up there. Do we have a couple of minutes for questions? So Jim, over to you.
Cool. And you answered, I think, some of the questions in there, but I just want to go back into it. And the question that came, oh, my it's better than having my mic off, I guess, doing my mime impression here. I'm back. How much collaboration is needed for the in-house IT team with SAS as a solution provider to get this solution in place? And I think that's particularly, both the people who are running these organizations don't have a lot of resources, but also I think want to know how to appropriately engage a vendor like SAS in this. So,
Jakob, do you want to speak about your real experience first?
Yeah, absolutely. So we connected with Sandy. He was incredible from the start. From an individual from another organization as well, and we've just been working very closely. It was more of like a very kind of close-knit relation. It was just a very like a close friendship and relationship as well, and explaining to him kind of our needs, what we're doing and sort of what we need. And because SAS has been very receptive of saying like, okay, well, maybe try this or maybe try that, and really kind of just forming that relationship at the beginning. And just I believe really just I think it kind of started from there really, and then just kind of evolved into being able to try out these new techniques and these new technologies that SAS had.
And for me, globally as well, we look to connect people together who have similar use cases. That's a big part of my role, is understanding who has a similar kind of story so they can collaborate with each other. But we at SAS also have resources. I mean, we have a significant number of PhD folks in the healthcare space who are able to engage as well to help people get momentum and get their projects running.
Yeah. And so, and you, I think you addressed a little bit of this, Greg, but what's the next big thing in healthcare? Obviously, this idea of getting the social metrics, bringing different data sets together is there, but what's the next big thing?
For me, it's interoperability and access to care for all. I do a whole presentation on the myths of healthcare. And one of the biggest myths is this idea that everybody's healthcare system is somehow different. And I've proved this out many ways by giving the same presentation around the world and people saying, yeah, that's my healthcare system. And then realizing that it's the same deck. Fundamentally, the differences in healthcare systems are the way they are funded and the way money flows through. But in reality, the needs are exactly the same. And I think the next big thing for us in healthcare globally is an understanding of interoperability, getting everybody's information into one place and using that to define care pathways for the individual that build on the best practice that we see around the world.
Yeah. Okay. And where can you get that presentation? I know you can get the podcast. You mentioned the podcast. Where can you get a hold of that presentation if you wanted to get some more information from you?
So people can email me, but the video of me talking about the biggest myths in healthcare is also available on YouTube and can be found there. But if anybody wants to email me or find me on LinkedIn and drop me a note, I can point them in the right direction as well.
Yeah, a big message, and also applicable everywhere. I think these issues these are everywhere, but there's just so nice to hear about when we're making a change in people's lives. Thank you very much, guys, and we're going to move on to our next presentation. Yep. Take care, and we'll be in touch. Thanks.
Thanks, Phil. Bye.
Thank you. Thanks, everybody.